He's been here for 9 years. Time flies. And works intimately with us in transplant with the Hepatobiliary program. So Sandeep's going to wow us with some of his stuff here.
Can you guys hear me okay? All right. Good morning, everybody. Thank you, Ken. It's a real pleasure to be here this morning. Thank you for the invitation. And this is my first time here under the auspices of transplant. So I thought this would be a nice opportunity for me to introduce the team and give you a little idea of who we are and what we do. So we do a lot. It won't fit into a 45-minute segment. But what I thought I'd do is pick the topic of pancreatitis. You know, this pancreatitis, transplant, doesn't seem like a logical fit here. But you guys are probably coming across a lot of our patients that are starting to come through for pre-op assessments. And so I thought I'd share with you a little bit of what's happening on the forefront from our side of it before they get to you. So what I'd like to speak today about is the endoscopic role of pancreatitis. And this will hopefully be one of a series of many lectures that I get to give, assuming Ken invites me back. But so where are we? What are we? We are the Pancreas Center. And although we live in cyberspace currently, we hope to live ultimately between kidney and pediatrics. When we get to that point. But joking aside, we actually, whether you guys realize it or not, have an incredibly unique program here. We really have one of the few programs in the country that offer a multidisciplinary approach to not only adults but children with pancreatic disorders. We are really one of a kind. We formed, although as Ken mentioned, we've been working together for years and years and years. We really formally formed this union about 2 years ago, where the advanced endoscopy team merged or came under the auspices of transplant. And now we have both a medical and surgical component, as well as an IR, genetics, and oncology component to our Pancreas Center. And therefore, we now can really offer an A to Z complement of diagnostics and therapeutics for again, children and adults with pancreatic disorders. So today we're going to touch upon just one small aspect of that. And really what we're talking about is this small little organ that's 4 to 5 inches long in the middle of your abdomen that was initially found, I guess, by a Greek anatomist surgeon named Herophilus back around 300 BC. And what pancreas actually stands for, what literally means is all flesh. It's a fleshy organ, probably described this based on what he saw and what he felt. And it's a cute little organ. There's no doubt about it. It's a lovable organ. But for years and years and years and centuries, actually, we've really known it to be the tiger of the abdomen. We don't, for most of us, except maybe 3 of us in the room, 4 of us in the room, really don't like to touch the pancreas. We at all costs try to avoid the pancreas. We have taken the opposite approach, and we make a living dealing with people's pancreas, and that's what makes us a little bit unique. But this is a nice quote that came from Steinberg about 2 decades ago. From mild disease to multi-organ failure and sepsis, pancreatitis is a disorder that has numerous causes, an obscure pathogenesis, and often an unpredictable outcome. And this is probably the best summary sentence I've ever found to describe our true respect for the pancreas. Okay, so like I mentioned, what we do in our clinic, our Pancreas Center clinic really founded its roots about 7 or 8 years ago. It's currently housed at the Mark and ultimately will be housed in the new transplant clinic. But what we do, we are the gatekeepers for people with pancreatic disorders. And what we try to do is find the appropriate path to take care of these people, whether it's medical, endoscopic, or surgical therapy. What we'll focus on this morning over the next 30 or 40 minutes is really the endoscopic approach and what we offer these folks. So what is endoscopy? What are the tools that we have to use? I think most of you have heard about ERCP as it relates to our liver transplant patients. What it is a side-viewing endoscope that we pass orally under anesthesia, pass to the second portion of the duodenum. Let me see if I have my pointer. So we go through the esophagus, stomach, to the duodenum, where we find the ampulla of Vater. We access the ampulla with plastic catheters, and then we inject contrast into the respected duct, whether it's bile duct or the pancreatic duct, and we take x-rays. We do this under fluoroscopy, and good morning, Sean. It gives us a silhouette of the biliary tree or the pancreatic duct, and we can make a diagnosis based on what we're seeing. Not only can we make a diagnosis, but then we can cater the type of therapies based on what we see. So it's a nice diagnostic tool. It offers us a complement of therapies, which we'll go into a little bit later in the talk. Now that is complemented by another endoscopic tool known as endoscopic ultrasound, which we brought to the school about 7 or 8 years ago. And how this differs from what I just showed you is that this is it's a traditional scope that has a transducer, an ultrasound transducer at the tip of it. And so we can, again, pass it orally into the stomach and duodenum, and then we flick a switch, and we can then do an ultrasound exam through the gastric wall or duodenal wall to see adjacent organs. So it's much different from a standard endoscopy where we only see the contents of the upper GI or lower GI tract. Here what we do are, depending on where the scope is planted, we can either see mediastinum, we can see adrenal, kidney, pancreas through the stomach. Through the duodenum, we can see head of the pancreas, bile duct, liver, porta hepatis, sometimes the right kidney and right adrenal gland. So it's a remarkable tool that gives us incredible resolution of these organs that cannot be seen by CAT scan or MRI or transabdominal ultrasound. So the complement we're talking about is ERCP EUS. How do we use these tools in patients with pancreatic disorders? So many of us feel that pancreatitis is a continuum of disease. People can get acute pancreatitis or inflammation of their pancreas for multiple causes. And you'll have one of two outcomes from this. Either you'll spend 4 or 5 days in the hospital and you'll have complete resolution of your acute pancreatitis and you'll never look back. And luckily that's a majority of the patients. In rare cases, about 20%, people can get a severe attack of acute pancreatitis that then leads to complications. And I think we've all heard of these, either pancreatic necrosis, pancreatic fluid collection, pseudocysts, walled-off necrosis, smoldering pancreatitis. That's what we call complicated pancreatitis, and that can be a long road. The mortality in that situation in some people can be as high as 40%. So it's almost like flipping a coin. When you have severe necrotizing pancreatitis, there's a 50-50 chance whether you'll leave the hospital. So this is where the tiger comes out, and we can't always predict who those people are going to be. So we respect pancreatitis, acute pancreatitis, for that very manner. Now, in some people, they can continue to go on and develop further attacks of pancreatitis. And we call that acute recurrent pancreatitis. People can get 1, 2, 3, 5 attacks in a year, and this is what we call acute recurrent pancreatitis. And almost all of these people then go on to develop chronic inflammation, or what we call chronic pancreatitis. Now, these people with chronic pancreatitis have an increased risk of developing pancreatic cancer, and occasionally people with occult pancreatic cancer can present with acute pancreatitis. So you see the circle here, the continuum of disease. And what we'll do for the next 30 minutes or so is talk about what's the role of endoscopy in all of these different scenarios. And I'll save cancer for my next talk. So acute pancreatitis, as most of us again know, over 80% of the causes of pancreatitis fall under two categories, either stone disease or alcoholism. And unfortunately, that seems to be in most healthcare folks, that's the armamentarium, or that's the book, or that's the differential diagnosis for everybody that walks in with acute pancreatitis. If you don't have stones, you must be an alcoholic. And that's really unfortunate. That's just pure ignorance on our part. We make a living taking care of these 20% who don't have stones and don't drink. And there are a lot of people out there that fall into that category, that really get shunned by the system, by the ERs, by their primary care docs, even by their gastroenterologists, and for the most part, never get to the bottom of why they've got these recurrent attacks of pancreatitis, why they develop chronic pancreatitis. And if we don't know why, we certainly can't do anything about it to change the natural history of their disease. Okay, so hopefully I'll shed some light on their stories. So how does stone disease cause acute pancreatitis? Well, as most of us in this room know or have, we have gallstones, especially in Southwest. We have stone disease, we have gallstones. And a majority of these people, and majority of us, they're asymptomatic. We walk around with these stones and we don't even know we have them. Until one day, the stone blocks the duct that drains the gallbladder. It's called a cystic duct. And that causes our gallbladder to get inflamed, what we call acute cholecystitis. Occasionally, in about 20% of people, that stone can then fall into the bile duct. And it's what we call choledochoscopy, and that can cause right upper quadrant pain. It can cause blockage of the bile, which then leads to a backflow of bile into the liver and cause a hepatitis. You can get jaundice from this, so you can get pain, nausea, vomiting, and jaundice. Sometimes you can get an infection, which can be life-threatening, what we call cholangitis. Now, if that weren't bad enough, that stone, if it were to come all the way down to what we call the common channel, the pancreatic duct and the bile duct in most folks come together at the level of the ampulla. For just a small section here, we have what's known as the common channel. And if the stone gets stuck or passes through that common channel, it can cause transient obstruction of the pancreatic duct, cause pancreatic duct hypertension, and that hypertension can then lead to an attack of acute pancreatitis. So who needs an ERCP? Who needs an ERCP when they have acute biliary pancreatitis? So what we mean by acute biliary pancreatitis is somebody that comes in with pancreatitis and has evidence of stone disease, either an ultrasound that shows gallstones, a CT or an MRI that shows a dilated duct, common bile duct, perhaps even with a visible stone in the bile duct. That's what we call acute biliary pancreatitis. Do all people that come in with acute biliary pancreatitis need ERCP? And the answer is no. And this is a nice study that was done by David Carlock back when he was still in England. Now he's in New York after many, many years at the Brigham. But this is really a landmark study that he presented or published in Lancet. And there are 4 other studies now that really have shown us the same thing. And that is, if we stratify these patients with acute biliary pancreatitis, and there are many ways to stratify patients, either by CT scan, Apache scores, Ranson's criteria, based on some physiologic and serologic markers. But if you can group patients into either severe pancreatitis or mild pancreatitis based on these scoring systems, what he found was that the people that benefit the most from ERCP in this setting are the patients that have severe acute biliary pancreatitis. These are the patients that most likely correlate to having a retained stone. And what he found was that if you do ERCP in the first 72 hours in these people, you can have, and stone extraction, you can markedly decrease the rate of complications, intra-hospital complications, and death from pancreatitis. And that really didn't hold true for the mild group. Whether you did an ERCP or not, it didn't seem to affect the patient's overall natural history of that hospitalization or chances of death. So and this is something we probably answer 4 calls a day sometimes, or a week. Patient has acute biliary pancreatitis, we want an ERCP, and this is the algorithm of these studies that we follow here at university. So how do we go about taking out these stones? We've gotten very, very, very good at this over the years. Historically, this was an operation. This was a common bile duct exploration. And since the early 70s, we've sort of switched the algorithm to endoscopy with the advent of biliary sphincterotomy, which was my mentor, was the first person to do this in America. We pass our side viewer. We identify the ampulla of Oddi. Let me see if the videos work. We cannulate with these catheters that I was telling you about, and these catheters have a cutting wire on them that can conduct thermal energy. So once we've accessed the bile duct, we can, with bipolar energy, cut the muscle, and then use various tools, balloons, baskets, to extract the biliary stones. And we're pretty good at this. Over the last couple of decades, we really haven't made a whole lot of progress, but some have felt we don't need to make progress. When we use balloons, baskets, or crushing baskets, what's known as a mechanical lithotripsy, we're successful in extracting stones in almost 85% of patients. And that's not bad, meaning only 15% go on to surgery. Now, the problem is, again, present company excluded. We've gotten so good at this over the last 30 years is that our surgeons don't get trained anymore on how to do this common bile duct exploration. Again, present company not included. So our feeling when we got here, we see so many people with stone disease here at the U. 15% of a very big number is still a significant number. And what we decided was that we needed to find a better way of taking care of these 15% of people. So let me share a little bit of some of our work here at university. Back in 1987, I believe, Wayne Swessinger, one of our own general surgeons, did something very novel. And he was in a case where he had an impacted cystic duct stone that was causing a Moritz syndrome. And he had the foresight to pull a holmium laser generator into the OR. And through his urethroScope, he blasted this stone with holmium laser. And it was the very first case report of using holmium laser in the biliary tree. And then he dropped it. He dropped it. And one day I didn't know this until years later, after I was knee-high in our research, and he was at one of my lectures, and he said, "Sandeep, do you realize that I was the very first person that did this?" And up to that point, I was taking all the credit for what I thought was my idea. So I said, "Okay, deal will be every time I give my lecture from now on, I will quote you and I will credit you for discovery of this technology." But what we do, our feeling was that laser would give us a nice, safe modality in which we could fragment stones and then extract these really big ones. And the way laser works is that we pass a small scope, and I'll show you what that looks like here in a second. But we pass a small scope in the bile duct, and we visualize the stone with cholangioscopy. And then we pass this laser fiber through the scope and pass it right onto the level of the stone. What the laser does, as you guys know, is laser's optical energy. It's a low level or low energy source that then evaporates the water instantaneously at the tip of the probe. It creates a cavitary bubble that then oscillates. That oscillation of that bubble creates a shock wave, and that shock wave breaks the stone. We use holmium laser. There are lots of lasers that we use in medicine. We picked holmium particularly because of its favorable wavelength. The wavelength is similar to that to water. and therefore it gets absorbed in this media and it causes very little scatter or trauma. So it's really a nice precision tool where we get the effect we want without any complications. We went to the animal lab and we worked out the power settings that should be used and how it should be used. And this is what it looks like. So this is passed through a conventional duodenoscope. We cannulate the bile duct as we normally do. We leave a guide wire in the bile duct, and then as opposed to just relying on contrast and fluoroscopy, we actually pass a little mini scope through the working channel into the bile duct so we can visually, with video, see the stone. Then we can apply the laser right onto the stone. And this is what it looks like, guys. So. Okay. So here's our typical San Antonian patient with these gargantuan bile duct stones that there's just no way with standard techniques that this is going to come out. You know, you've got a huge mismatch between stone and duct. So this stone has to get fragmented. So here you're seeing the laser probe right on these big stones here. And we place the laser fiber right onto the stone, and we hit the pedal for 5 seconds at a time between 8 and 12 watts, as we've determined in the animal lab. And we fragment these stones into much more manageable pieces. And once we've gotten to that point, then we can extract them with the tools that I've talked to you about before, whether they're baskets, balloons. And we can usually do this all in one setting. So we then were the PIs for a multi-center clinical trial. We recruited Dallas, Houston, and New York City. And we recruited 74 patients that had these refractory stones. And by refractory, what we meant was that they had had anywhere from 1 to 6 failed ERCPs with attempted extractions. Then they were referred to one of 4 centers. We did ERCP, cholangioscopy, laser lithotripsy. These stones were all over the place. Most of them were extrahepatic, some were intrahepatic, some were in the cystic duct. We had a separate study that we've now expanded on and have just published on pancreatic stones. And what was neat here is, again, we're talking about this 15%, these 15% of people that are refractory to standard ERCP. So these are a tough group of people. And in that group of people, we were able to get bile duct clearance in 97.3% of patients. A majority of the time, 75% of the time, we were able to do it in one session with a low morbidity and a complication rate of 4%. And that's pancreatitis, hemophilia, all things that were self-resolving. So that's acute pancreatitis. That's acute pancreatitis related to stone disease. We've gotten pretty darn good at taking care of that. So we'll switch gears to complicated acute pancreatitis. As I mentioned, when you have severe pancreatitis, as opposed to your mild interstitial pancreatitis where the gland completely comes back, resolves, the water gets reabsorbed, and you go on until another day, these people have such an outpouring of fluid and third spacing that in the resolution process they can create pockets of fluid that are then encapsulated by inflammatory fibrous rind. And that's what we call a pseudocyst, or in the setting of necrosis, a walled off necrosis, collection of necrosis. These people can get abdominal pain, symptoms of food intolerance because the pseudocyst has gotten so big that it's pressing on the stomach or pylorus or duodenum, and they can get gastric outlet. So they can't eat, they get nauseated, they're throwing up. They can get infected, and you can get a pancreatic abscess and thus get abdominal pain and fever. Historically, the therapy was surgery and percutaneous drainage, and this still works very good. And outside of major tertiary referral centers, this is probably still the means of treatment. Here at UT, we like to use a multidisciplinary approach. I'll I don't know how many times I've called Dr. Woolley for these complicated cysts, and we may use a complement of percutaneous drainage, endoscopic drainage, and if we fail, then we can go to surgery. But let me share with you how we manage these endoscopically. So the reason these lend themselves nicely to endoscopic treatment is because of geography. The pancreas sits right along the posterior wall of the stomach. So we can plant our scopes right here in the stomach, and then as I showed you earlier, we can visualize these cysts nicely with ultrasound, and we can create a fistula. We can puncture these cysts through the gastric wall, create a fistula, and allow these cysts to drain into the stomach and then pour out through the GI tract. And this is what we call a cyst gastrostomy. We can do that same thing from the duodenum. So that's what we call a transmural approach through the wall of the stomach, a transmural drainage of pseudocysts. Some of these pseudocysts, by definition, connect to the pancreatic duct, and it's like a fire hydrant. The fire hydrant, as you know, the pancreas makes a ton of fluid, pancreatic juice. This juice then goes down the duct and into the intestine. Well, in some people that have pseudocysts, the fluid then preferentially goes into the pseudocyst, and it's just continually filling this cyst with fluid. So we can take a transpapillary approach, as I showed you with ERCP, get into the pancreatic duct, bridge whatever blockage is causing the preferential fluid to go up the pseudocyst rather than the duodenum, and allow fluid drainage into the duodenum rather than into the cyst. So that's what we call a transpapillary approach to a pseudocyst. Sorry. All right, so this is what I was talking about in terms of the progression of disease or the natural history of somebody that might have this complicated pancreatitis. So here you have pancreas, and this is somebody with acute pancreatitis. A few weeks later, the pancreas is starting to look a little clearer. Some of this peripancreatic inflammatory changes, the fuzziness that you see around the pancreas is starting to resolve, but we're starting to form a small cyst. A few weeks later, the cyst is now grown into a big cyst, and you can see this little rind that I'm talking about, this little white rind that goes all the way around the cyst. That's a pseudo rind, or that inflammatory rind. And this thing is so big that it's actually starting to pinch off the antrum of the stomach right at the level of the pylorus, and it's causing this person some symptoms. Here you've got a nice MRCP that shows this cyst in very close proximity and probable communication with the pancreatic duct. So how do we take care of these? So there are two ways. We can puncture these directly. This is in the duodenum by stabbing it with a needle, then passing a guide wire into the cyst. So we do this in endoscopic and fluoroscopic view. Here we've got an EUS image, so we're doing this via EUS-guided. But the concept is the same. We get access, we get a wire, we dilate the tract with a balloon, create the fistula, and then keep the fistula open by placing stents between the cyst and the GI tract. In this case, we're in the duodenum. In this case, we're in the stomach. And as soon as we do that, we get an outpouring of fluid that now comes into the duodenum. And over a matter of sometimes a few days to weeks, that fluid then in the cyst decompresses. We follow that with CT scan. Once it's resolved, we come back and we pull the stents out. In this particular person, I'm showing you an example of the transpapillary drainage where we documented a leak in the pancreatic duct, and we're placing pancreatic duct stents. So we can put plastic stents, or we can put, more commonly what you're seeing us do is placing larger diameter, removable metal stents, and we just published a study on using these stents as well, and have found less migration, less infection by placing these really big, wide bore stents into these fistulous tracts, and you can see the fluid just starting to ooze out. You know, surprisingly, they don't. You know, they do if we have this. So if we drain the cyst transmurally and we leave a leak behind, and so here you have a pancreatic duct, and here you can see a little spewing of contrast into this free space, which is well contained, and it's a nice example of a extravasation of contrast into a collected space and a cyst. So this is that very example I was telling you about in some of these people that have communicating pseudocysts. If we do a transmural drainage and we leave this behind, then absolutely they'll come back, Ken. So we have to make that decision at the time of endoscopy whether we're going to take a transpapillary approach as well. But if we take care of both, usually not. Now, we have one patient in the hospital currently that will say differently, and so it's not a perfect science. This is a neat patient. This is an example of doing an endoscopic necrosectomy. This is somebody that came from the outside, had a previous cyst gastrostomy. This is what his cyst, a really walled-off necrosis, looked like before. After they placed the stents, he got infected. And you can see that we remove the stents, and we make a big opening from the, well, big for endoscopists, tiny for surgeons, but we work our way so that we get the scope within the cyst itself. Now you can see this cavity, and there's just no way this gunk, and this is the stuff that you peel out with your hands, but there's no way this stuff's going to come out through a stent. So we go in and with tools that are really not made for this, try to debulk, try to peel this necrotic debris off this lining, and we meticulously debride these people endoscopically. We pull this material back into the stomach, and it's a real tedious process. We can take anywhere from 1 to 4 to 7 sessions. We used to do them in the hospital, keep the patients here and bring them to the endo lab every 3 days. Now with the advent of some of these really big stents, we've started doing these on an outpatient basis. So they'll come in on a weekly basis, and we'll bring them in once a week. We'll debride some. We'll leave the stent back in. We'll wash it out for a week, and then we'll bring them back. And at the end of it, this is what we're trying to achieve. Nice granulation tissue with no necrotic debris. And now this will close by secondary intent. So this is an operation that I found that my colleagues don't really like to do because it's tedious and time-consuming, and it's a big recovery time for the patients because we usually leave their wounds open. And here we can do it essentially closed. All right, we wrote a review on this and looking at, well, where does endoscopic treatment or management of cysts, I'm not talking about necrosis, I'm talking about simple pseudocysts, fall in relation to percutaneous, surgical, and endoscopic approaches. And what we found was whether transmural or transpapillary, I'll just relate to combined techniques, our complication rate was similar that to the lesser invasive percutaneous approach, but our resolution rates were comparable to surgery. So we're getting the benefits of the surgery with the lesser complications of percutaneous therapy. So it's a nice, it's sort of the best of both worlds in the right patients. All right, so let's switch gears. We've talked a lot about acute pancreatitis. Now we're going to go into acute recurrent pancreatitis. These are people who have repeated attacks of acute pancreatitis, usually 2 or more per year. And like I mentioned earlier, these people usually progress to chronic pancreatitis. These are the people that make up that 20%. And there's a whole slew of reasons why this can happen. And the whole basis of our center was to develop the skill set and technology to be able to make the diagnosis in these patients, whether it's metabolic causes, infectious causes, genetic causes, congenital causes, anatomical causes. We now have the complement of tools, scope, skill set to look at these patients and make a diagnosis. So rather than 20% of people being idiopathic, meaning we don't know what the hell's causing your disease, we have really cut that down to about 5%. And the goal of endoscopic therapy or medical therapy is to prevent further attacks of acute pancreatitis and hopefully change the natural history of these people from developing chronic pancreatitis. So I'll go over a couple of the main causes of this. One is pancreas divisum. You may or may not have heard about this. And this is a congenital abnormality where the dorsal pancreas fails to fuse with the ventral pancreas, usually under normal circumstances. Again, your pancreas makes all this protein-rich fluid that then gets excreted into the main pancreatic duct and then drains out of the main pancreatic duct through the ventral duct out of the major papilla. And it's an I-10 highway. Great, no problem. Well, in people with pancreas divisum, that connection isn't made. It just fails to fuse and it's non-existent. So the main pancreatic duct actually has to drain out of a much smaller farm road and then out of a much smaller opening called the minor papilla. And in a small percentage of people, not all people with divisum, but in a small percentage of people with divisum, that causes outflow obstruction of pancreatic fluid. And we generally start to see this in kids as they're going through their adolescent growth spurts. Their gland as the gland grows and the more fluid it starts to produce, at some point their ductal system is unable to accommodate the amount of volume. And the one thing we know about pancreatic fluid is it's not meant to be stagnant. Pancreatic fluid is caustic. It's like liquid Clorox. It's Drano. It's not Drano at first, but it's got an activating portion to the enzyme, trypsin to trypsinogen or trypsinogen to trypsin. It's usually activated in the intestine. If that pancreatic fluid stays in the pancreas too long, there can be premature activation of this fluid in the pancreas itself, and that's what causes the autodigestion of the gland. So in a sense, the gland is eating up its own gland if there's outflow obstruction. And this is what it looks like on endoscopy. Here we have our duodenoscope in the cobra position, our long position. Many times it's really difficult to find the minor papilla anatomically. We have some tricks to do that. And you can see that you've got well, you'll have to trust me, that this is a dilated pancreatic duct, and then it really becomes quite ectatic and narrowed. And this is the dorsal duct component of it. So you've got outflow obstruction here that's leading to high pressure and swelling and distension of the main pancreatic duct. So this person is not draining their pancreatic fluid very well, which is then leading them to develop recurrent bouts of pancreatitis. So what we can do for these folks is we can do a minor papillotomy or a sphincterotomy of the minor papilla. We can do serial pancreatic duct stenting and try to widen that road so that it's no longer a farm road, but it's more of an I-10 type of situation. And there's many studies, most of them done early on in the mid-80s, mid-90s, that have shown that in people with acute recurrent pancreatitis, if you offer them endoscopic therapy, whether it's sphincterotomy or stenting, that you can improve their symptomology in almost 80%. Meaning, if they have daily pain, they no longer have daily pain. If they have 2 bouts of pancreatitis, they no longer have bouts of pancreatitis. So pretty good in people who have got acute pancreatitis and not yet quite developed chronic pancreatitis. In this group of people, we're okay. We can still resolve their symptoms in 45 to 50% of the time. And the reason we're not quite as successful, because by the time they develop chronic pancreatitis, now they've got sort of a multifactorial reason to have developed pain and their other symptoms. And I'll get into that in the next chapter. We try to stay away from people with pain only without bouts of pancreatitis for obvious reasons. The other group of people that we see is people with Sphincter of Oddi dysfunction. And what that is their ampulla of Oddi has become diseased. Either in the form of becoming stenotic, what we call sphincter stenosis or papillary stenosis, or their valve has become dyskinetic or spastic, and it goes into inappropriate contractions for prolonged periods of time that therefore cause, again, outlet obstruction. So it's just a different form of outlet obstruction from a different cause. And a little anatomy here. There's a muscle that surrounds the bile duct called the Choledochoscopy. There's a muscle around the pancreatic duct called the Pancreaticus. And then there's a figure of 8 muscle that goes around both called the ampullae. And when this muscle configuration becomes diseased, it can either cause outflow obstruction of the bile duct, which would then cause right upper quadrant pain with jaundice, LFT abnormalities in the post-cholecystectomy patient. It's what we used to call post-cholecystectomy syndrome. It occurs in 1% of all people who undergo a lap chole, and these people fill up our general surgery clinics with recurrent abdominal pain after a lap chole. So we can either check their biliary pressures, or in the people that we're talking about, it can also be a cause of idiopathic acute recurrent pancreatitis because of the stenosis or dyskinesia that it causes in the pancreatic duct, in which case we gear our treatment toward the pancreaticus. And it's a pretty elaborate process to check for this. There are only 5 centers really in America that do this pretty well. And you really need this mad scientist type of apparatus, a water perfusion system, catheters, know-how like my team right here in the front row of how to work all of this equipment. And these are high-risk patients. These are patients that have been ill for a long period of time. And these are the highest risk patients for developing post-ERCP pancreatitis. So for both reasons, the average center will not want to or can't provide care for these people. But it's a significant population and number of people epidemiologically that have manifestations of disease because of this. So we do it. And what it essentially is a passage of these catheters through the papilla. And it's not that exciting anyway, so don't worry about it. And as we pass these manometry pressure catheters, that's funky. It's playing behind the curtain. Anyways, it's all right. We do a simple pullback once we've cannulated the papilla, and these pressure transducers then give us a recording. Based on the waveforms on that recording, we can make a diagnosis of either sphincter stenosis or sphincter dyskinesia. Once we've found that, the treatment is biliary or pancreatic sphincterotomy. And again, this is work that came from my mentor, or one of the fellows from my mentor, that really coined this term, Sphincter of Oddi dysfunction. And what he showed in this randomized study that has never been able to be replicated because of what we're talking about and the morbidity associated with this procedure is that in patients that you find elevated pressures and offer them treatment, there's a significant improvement in symptomology compared to the sham or the placebo group. In people with normal pressures, as you would expect, there's a slight placebo effect, but this was quite significant. And this is the study that was quoted for 20, 25 years now, along with a couple of scattered studies from South America and Germany. But if you can make the diagnosis objectively with Sphincter of Oddi dysfunction and treat them, they tend to do quite well. All right, again, now finally we'll talk about and wrap up with chronic pancreatitis. And one of the challenges with chronic pancreatitis is making a diagnosis. Making the diagnosis of chronic pancreatitis and then offering treatment. This is a tough group of people to take care of in terms of trying to prevent further attacks of acute on chronic pancreatitis or to alleviate their daily symptoms. These are people with horrible quality of life that really have not been offered too much in the form of treatment or therapy over the years, and because of that have become really desperate for any kind of care and really seek us out. They're almost relieved when they find us. Again, one of the major problems pre-EUS, pre the advent of EUS, is making a diagnosis in people with mild to moderate chronic pancreatitis, which is a majority of these people. They, symptomatically, they will have abdominal pain. They may or may not have diarrhea. They may not have steatorrhea. They will have weight loss. You may have a high clinical suspicion of chronic pancreatitis, but we just can't prove it. Their CT scans are normal, their abdominal ultrasounds are normal, MRI, X-ray, their radiographic studies tend to be normal in these people. Their function tests tend to be normal, and that's because you really have to blow out 90% of your gland before you start showing signs of exocrine dysfunction. So, I mean, that's pretty, by definition, that's severe pancreatitis. You have to have severe pancreatitis before your stool tests will show us a diagnosis. We can do secretin stimulation studies and functional tests. They're quite invasive. And again, these are not available at most centers, and it's a pretty invasive test of trying to determine this. So this has really fallen to the wayside. EUS has really changed the game in the world of pancreatology. Prior to EUS, we used to make a diagnosis based on ERCP. Again, another very invasive test to check for this, and you again have to have pretty severe disease before this starts to show up on your pancreatogram. And this is our Cambridge classification. This is what I was taught in fellowship, again, as EUS was starting to evolve. And again, EUS has really changed the game. We can now make the diagnosis of chronic pancreatitis based on sonographic findings and sonographic criteria that have been fairly well bore out over the last 10 years. We look at parenchymal features, we look at ductal features, and the more of these features you have, the more specific this test is in terms of the diagnosis of chronic pancreatitis. And this is a gland. You can see the pancreatic duct right here in the middle. Normally the gland, and I don't know if I didn't really point it out on the first slide, but it has a nice salt and pepper appearance, very clean, very homogeneous. This one you can see is lobulated, it's black, it's got, it looks like it's got hyperechoic margins to the pancreatic duct, what we call the railroad sign. It's cystic, it's got hyperechoic strands, hyperechoic foci. So right off the bat, this person has about 4 to 5 criteria that we're talking about for chronic pancreatitis. We can make the diagnosis and now start looking for the etiology of their chronic pancreatitis and start treating them. So if we see an outflow obstruction, we can treat that. If it's small duct chronic pancreatitis, as we're seeing here, we can treat their neuropathic pain in a different way, either with medicine or else. And that's what I want to highlight with this. So we have these people with chronic pancreatitis, with pain, and we have all these different things we can offer them. Pancreatic enzyme supplementation, analgesics, low-fat diet, obviously abstinence from alcohol or nicotine, octreotide, which we don't use very often. We will use that in the setting of pancreatic leaks. We have our endoscopic armamentarium, and if all else fails, we can offer surgical therapy. And as I mentioned, I'm kind of driving home, endoscopic approaches are one of one of two approaches, either treatment geared toward relieving outflow obstruction, or what I haven't talked about is treatment towards neuropathic pain that these folks develop. As their gland becomes fibrotic and inflamed, the sympathetic, parasympathetic ganglion that embed the gland develop a neuronitis. That neuronitis is then transmitted back to the brain and gives a sensation of pain. So there is treatment geared towards neuropathic pain, either pharmacologically with drugs such as gabapentin, or with endoscopic or a percutaneous celiac block, which I'll show you in a second. So getting back to obstruction. Obstruction we already have talked about can occur at the level of the valve, or it can be congenital. You can also get obstruction because you've developed stones in your pancreatic duct. And as I've talked about before, with on the biliary side, we have a armamentarium of tools to relieve this or to extract these stones, baskets, balloons. What we've done in our lab in patients with stones that are refractory to standard techniques, we again use our laser probe. So here we have the pancreascope in the pancreatic duct. We have a pretty sizable pancreatic duct stone. And it's a little fuzzy, I apologize, but these stones actually respond quite well to the laser lithotripsy. and they almost chalkify as soon as you touch them. And so we can fragment them again into much more manageable pieces. And in the pancreatic duct, we don't have as much room to work with. And so our balloons and baskets and mechanical lithotripsers are a little more limited. The anatomy is convoluted. You've got side branches. It's much more tricky to operate in the pancreatic duct than it is in the bile duct. So we have to resort to this more frequently. And that's how this works. And we've just compiled our study on our first 25 patients of doing this. Again, it was a multi-center trial. We included Denver in this one, and that's coming out later in the next couple of months. So as I was mentioning, the management of endoscopic management of pancreatic duct stones is much more difficult. We're technically successful in only about 62% of patients. Again, this does not include laser. These are with standard approaches. And of these people that we're successful in, we get a symptom relief in about 60%. So again, the response rates aren't quite as good as our people with acute recurrent pancreatitis. And again, that's because they have a multifactorial cause of their pain. It's not just obstruction. Here's an example of somebody with a very, very tight pancreatic duct stricture that goes almost, again, this person's got divisum from almost the head of the pancreas all the way out to the tail. It's a really long, probably 7-centimeter stricture, and with upstream dilation of the duct. We can place a stent to bridge the stricture, and we can do this a few times. We can serially dilate the stricture until we've had complete fluoroscopic resolution of that stricture. And similarly, it works about the same, except our technical success is much higher. This is much easier to do than extraction of pancreatic duct stones. Our technical success is almost 100% with resolution of symptoms in about 73 or 72% of patients. All right, this is neat. All right, this is EUS-guided treatment. I think Michael will enjoy this. One of the benefits of what we can do here with EUS is we can see the aorta and the celiac take off really nicely. It's only about 1 centimeter away from the GE junction. What we can do very easily, probably a little easier than our percutaneous friends, is we can access the celiac trunk, which is where we feel the celiac ganglion live. And by putting a needle in that space, right at the celiac takeoff the aorta, we can then very clearly, very nicely, we can use Doppler flow to identify the vessels, but we can then inject anesthetic like Marcaine or along with a steroid like triamcinolone in that space and cause and give these folks a celiac block. In patients with terminal pancreatic cancer and really debilitating pain, we can inject 100% ethyl alcohol in that space, and we can then completely ablate the ganglion and give these folks symptom relief. So it's really quite accessible for us right at the gastroesophageal junction with our EUS scope. We can identify this space, and then we can put a small needle through the gastric wall into that space and inject either alcohol or steroid. And our response rates are pretty good to this. In people with cancer, we get a complete response. And these people are on narcotics, morphine dilaudid, on big dose narcotics. But even in these folks, we can get 80% relief of their pain. In our chronic pancreatitis, again, because of what I mentioned before, their pain is multifactorial. But despite that, we can still get about a 50% response rate with these celiac blocks in this really desperate group of people. So last 3 slides are in summary, and I'll wrap up, is that our approach to patients with pancreatitis, chronic pancreatitis include therapies that are towards outflow obstruction, sphincterotomy, stone removal, PD stenting. Those that have neuropathic pain, we offer celiac neurolysis. And contrary to popular belief, surgery is not a bad option in good hands for these people that have disease that's refractory to medical and endoscopic treatment. And for those people, we then call our colleagues within the center, and we can offer surgical sphincteroplasty. We can offer drainage procedures like a Pusteau or a Fry. We can do localized resection surgeries, a Whipple or a distal pancreatectomy, or in some cases, we can remove the gland completely, do a complete total pancreatectomy, and as we heard from Dr. Levy a few weeks ago, do an islet cell transplantation. So in summary, we've talked about acute pancreatitis and what we can offer these people, stone extraction or treatment of their pseudocysts. Those people that have acute recurrent pancreatitis, we can offer sphincterotomy, stenting, diagnosis. Those with chronic pancreatitis, we can make a diagnosis with EUS, relieve either their obstruction or their neuropathic pain. Some of these people go on to develop cancer, and hopefully what I'll have the chance to do some point this year is come back and talk about how we manage folks with pancreatic cancer. You know, whether it's your typical adenocarcinoma, neuroendocrine tumors, cystic tumors, or the pancreas, but this is a big group of patients that we are now starting to attract into our system. Again, we take a multidisciplinary approach to people with pancreatic cancer, and with our colleagues in surgery and at the CTRC, we hope to offer these people expedited, efficient care. So we can hopefully do that next time. Thank you for your attention. There any questions about what we talked about?
So I guess I didn't appreciate the celiac blocks you guys are doing. Pretty standard now.
Yeah, you know, so those of our folks that have chronic pancreatitis and are taking a narcotic of some sort, we offer all of those people a celiac block, at least once. We usually do it during a time when they're getting their surveillance EUS anyways, so they're not coming in specifically for the block, but if they are symptomatic and they're on a narcotic, my belief has been, and I think Dutch falls into this category, and so does Laura, that they get one chance of a celiac block, and 50% of them respond pretty nicely. So those 50% that respond, you know, will get 4 to 6 months worth of relief, and we may bring them back on a cyclical basis. And if after 3 or 4 of these sessions they're really doing pretty well, then we can send them to our percutaneous folks, and they can do a thermal ablation. We've even sent a few folks for a surgical, almost like a vagotomy type of thing, and they do quite well. So we do offer that. But you know, one thing I didn't get to do at the beginning is I wanted to introduce my team, because a lot of you guys haven't met us. You know, advanced endoscopy is made up of 4 endoscopists, myself, Dr. Vanderveld, Dr. Rosenkrantz, and Dr. Echevarria. Our MVPs of the program are the people that make our program operate, and that's Bob Edwards, John Wiegand, Mary Moran, Sean. We're kind of a small crew of 4 people, and then we have our folks in our lab that really make this magic happen, and thank you for coming today, Mike, Betty, Gloria, and Lisa. Okay, and we unfortunately don't have our folks here from UH up here today, but we operate out of 2 endoscopy labs at Christus Santa Rosa and UH. Our clinic is currently at the Mark, but hope it will soon move to UH in our new space. And that's our program. So call if you have any questions or problematic patients. We're here to help you. Thank you.